Hi students, you're listening to the lecture on management of patients with coronary vascular disorders. The objectives for this lecture: by the end you should be able to describe the pathophysiology, clinical manifestations, and treatment of coronary atherosclerosis, discuss the pathophysiology, clinical manifestations, and treatment of angina pectoris, discuss clinical manifestations and treatment of an MI, use the nursing process as a framework for care of a patient with angina pectoris, myocardial infarction, or acute coronary syndrome, describe percutaneous coronary intervention and coronary artery revascularization procedures, and apply the nursing process as a framework for care of a patient who has undergone cardiac surgery. Okay. Cardiovascular disease is the leading cause of death in the United States, with coronary artery disease being the most prevalent cardiovascular disease in adults. Atherosclerosis is an abnormal accumulation of lipid as well as fibrous tissue in the arterial vessel walls. This accumulation causes a partial or complete blockage, which reduces the blood flow or stops the blood flow to the myocardium. The anterior and posterior views of the heart, along with the arteries that supply oxygenated blood, can be seen here, and it should be a review from A and P. If you're not remembering it, then you'll make sure you go back and review that. Signs and symptoms depend on the location and degree of narrowing of the atrial lumen, as well as the degree of the obstruction. The obstruction can lead to myocardial ischemia, which can lead to angina, or if it's more severe, it can lead to an actual infarction, especially if it's not treated. There are modifiable and non-modifiable risk factors for coronary artery disease. The main ones, as far as non-modifiable, as we get older, we are at more of a risk. Family history is something that we look at. The male gender is at risk more than the female, and the African American population is more at risk. Modifiable risk factors: sedentary lifestyle, obesity, metabolic syndrome, which is where most of the weight is in the abdominal area, diabetes, especially type 2, hypertension, smoking, and hyperlipidemia. Risk factors for coronary artery disease: again, metabolic syndrome. You have the abdominal fat, more so where you carry your weight than anywhere else. This leads to insulin resistance. Dyslipidemia is also part of the metabolic syndrome. And then hypertension, which is a blood pressure greater than 130/85. There is something called the Farmington Risk Calculator, and this is used to predict your risk of cardiovascular disease over the next 10 years. You can go online and Google it and then see where you fall in the next 10 years as far as your risk for heart disease. As far as prevention, you want a low-fat, high-fiber diet. Mediterranean diet has shown success in reducing cardiovascular disease, and that's because it's high in consumption of fruit and vegetables. Low in carbs. Physical activity, you want to have at least 150 minutes of moderately intense aerobic activity each week, or 75 minutes of vigorous aerobic activity each week. You can also do muscle strengthening exercises, but you still need to have that aerobic activity. So you can add muscle strengthening exercises to it, but don't replace it. Make sure that medications are taken as they are prescribed. Don't stop them. If the patient is having some side effects that they don't like, they need to speak with the physician before they stop them and see if they can be switched. Encourage patients to stop smoking as well as stop drinking, and they need to control their diabetes if they do have diabetes. There are different medications that the patient can take. If you don't remember the cholesterol meds from pharmacology, go ahead and look at those again so that you are aware of which medications are for cholesterol. Sometimes patients will just say, I'm on heart meds. And so you have to be able to look at the medications and see when they say they're on heart meds, like what medications are they actually on. Cholesterol medication is one of those things that they'll say is a heart med. As far as angina pectoris, your patient will experience episodes of pain or pressure in the chest, and this is caused by insufficient coronary blood flow, which will result in lack of oxygen that is supplied to the myocardium, and that's what's causing the pain. This is generally caused by atherosclerotic disease, and it affects one or more of the major coronary arteries. If you have stable angina, then the pain is predictable. It occurs with exertion or activity, and then it is relieved by rest or taking nitroglycerin sublingual. If the angina is unstable, then the patient will have increased signs and symptoms, increased frequency and or severity, and the pain is not easily relieved by rest or nitro, and it does require immediate intervention, and that's when they need to go to the ER. Intractable or refractory angina is severe incapacitating chest pain. And so not only is the chest pain severe, it also is unable to be relieved from nitro and rest. Variant is pain that is at rest, and a patient might have ST elevation, but it is reversible. Most of the time, variant angina is caused by coronary artery vasospasms. And then the patient can also have silent ischemia, and so they have no signs and symptoms whatsoever. But if they have diagnostic testing, it will show ischemia on the testing. As far as assessment, you as the nurse must gather information about the client's symptoms as well as their activities, especially those that precede and precipitate the attacks. The client's coping, understanding of the disease, and status following the attacks are also important to know, but you have to know the causative factors because that's going to be your primary focus. If you know the causative factors, then you can talk to them about prevention or how to handle it. You will get a 12 lead and you'll want to look at that to see if you see any abnormalities. And then you also can look at the cardiac biomarkers, which are blood tests. Gerontological considerations, if you remember back to the beginning of the semester, patients who are in the older adult population do not have the same signs and symptoms. They have more vague symptoms. They also can have silent coronary artery disease or silent ischemic events. They can have cardiac cath to see what's going on, and they can have a pharmacological stress test instead of doing the stress test where they're actually active. And because they are older, they don't metabolize medications as quickly, so that needs to be implemented cautiously and at a lower dose if you're going to start medications. As far as treatment goes for angina, the treatment is going to focus in on increasing the oxygen supply and getting that blood flow back to the myocardial tissue. The patient can get sublingual nitro, and they can also have beta blockers, calcium channel blockers. They can get antiplatelet medications, anticoagulant medications as well. And the two work differently, so make sure you understand the difference between the two. You can put them on oxygen, and most orders are to keep the sats above 95%. And the patients need to learn how to control their risk factors. If they're modifiable, they need to be able to reduce or eliminate those risk factors, like no smoking, alcohol consumption, high fat, high sodium diet, those things that they can change, they need to change. And they can have reperfusion therapy as well to try and get that nutrients and oxygen back to the ischemic cells. As far as assessment, look for signs and symptoms. How long do the symptoms last? What preceded the symptoms? What helped the symptoms, as well as what did not help. because the patients are told, try this and this and this and this, and you need to make sure that you know what worked, but also what didn't work. That way you know what they're trying, see if there's anything that they're missing. You also don't want to encourage them to continue to try things that aren't working for them. And then ask them about the history of episodes. And are they noticing it being more frequently? Is it lasting longer? Are there new things that are preceding these events? That way you can see any kind of progression if there is progression. And then talk to them about their compliance and adherence to the medical regimen. Okay. We have different types of interventions that you can do, and we'll talk about that in these slides. You want to treat the angina. That is your first priority because you do have decreased blood flow to the myocardium. Patient needs to stop all their activity. They need to sit and rest. They need to be in a semi-Fowler position. You do not want them laying down. Have them take deep breaths so that you can keep them calm. You can give them some oxygen and then give them nitroglycerin as long as they have an order for it. It will be sublingual. Make sure they do not swallow it. It does need to go under their tongue. And they can have it up to 3 times, and it's 1 tablet every 5 minutes. So every 5 minutes they can have another one if it's helpful. Okay. Make sure you monitor their vital signs. Make sure you monitor their respiratory status so they're not in any kind of respiratory distress. And then you'll also want to get them on an ECG. You can do a 12 lead and then you want the continuous monitoring as well. Make sure that you are calm, your tone is calm, and help them with coping, stress reduction. You can use distraction, you can use breathing techniques, guided imagery, but you need to keep them calm because increasing their anxiety is going to make the angina worse. Prevent and treat the pain if they are having pain. If extended activity is what causes the attack, then you need to make sure that they're very aware of when they become overexerted so that they can stop their activity and reduce their heart rate, and then also try and actually plan out periods of activity with periods of rest throughout the day. That way they don't get to the end of the day and they have more to do than what they can handle. You want to talk to the patients and the family about it as well. Okay. They should be on some sort of exercise regimen, but they need to make sure that they don't overexert themselves. They can get counseling, they can get support groups, there are different things that they can do. Make sure that they're aware of the medications that are over the counter that can increase their heart rate or blood pressure. They're always on the bottle, so they need to read the labels, and it always says if they have any kind of heart condition or if they're on blood pressure medications, that they need to contact their physician before they start it. Most of it is related to cough, cold, allergy medications, that sort of thing. Again, they need to stop smoking. I don't think we can say that enough. And then they should have a low-fat, high-fiber diet. Nitroglycerin needs to be with them at all times. It needs to be kept in a dark, cool place. So like here in Texas where it gets up to 140 degrees, they should not keep it in their car. They should keep it actually on their person at all times because you don't know when you're going to need it. Their follow-ups, they need to actually keep all of their follow-ups, and then they need to keep their routine visits with their physician as well. Even if they're feeling well, even if they haven't needed their nitro, they need to keep their follow-ups so that their doctors know what's going on. They need to report signs and symptoms to their provider when they have to take it. It's good if they keep some kind of a log. So if they take a nitro and it helps, they should write it down. If they take a nitro and it doesn't help, but the rest helps, they should write that down. That way they can kind of track what's going on, and they should write down what they were doing before and then how long their discomfort lasted. Acute coronary syndrome and myocardial infarctions are next. Patients will have an acute onset of myocardial ischemia, and it will result in myocardial death. And they will complain of pain, and the pain can be in different areas, and we'll talk about that. Women do have atypical signs and symptoms of an MI, whereas men typically have that, crushing chest pain. I feel like there's an elephant on my chest, or someone's wrapping a belt and squeezing my chest because of the pressure. And it can radiate down the left side, up the neck, and they can have tingling in their left arm or hand. That's typical as far as pain is concerned. Women generally have atypical symptoms. Sometimes the symptoms are vague. They might just be tired. They might think that they have indigestion. They might just have problems with nausea and vomiting. They can have palpitations. They can have back pain instead of having chest pain. An infarct can develop over minutes. It can also take hours to develop. It just depends on if they have a partial blockage or complete occlusion. The first signs are seen in the T wave if they have an ECG, as well as the ST segment. The T wave will invert due to the delayed myocardial repolarization, and the ST segment will elevate due to rapid repolarization after the depolarization. When you have an elevation on two contiguous leads, then the patient is most likely having a STEMI or an ST elevated myocardial infarction. The T wave can become abnormal 1 to 3 days after the infarct because there's no depolarization because of the necrotic tissue. The R wave can also decrease as far as the height goes if you're looking. As far as the nurse goes, you want to do a symptomatic assessment, and this includes a careful history, particularly as it relates to the patient's symptoms. So when did the symptoms start? What were you doing before the symptoms started? Do you have the chest pain and discomfort? They might complain of difficulty breathing or dyspnea, palpitations, unusual fatigue. They might complain of syncope. They might also have sweating or diaphoresis. For each symptom, you want to ask how long did it last, when did it start, and what precipitated the symptoms. Did you do anything that helped the symptoms or relieved the symptoms? And then have you ever had this happen before? If so, was it better? Was it worse? You'll also get vital signs. You'll ask about the atypical signs and symptoms. You'll get their heart rate, respiratory rate, blood pressure. You'll hook them up to a 12 lead, and then you'll also do the continuous monitor, and then you'll get cardiac enzymes and cardiac marker testing as well. As far as the biomarkers and the enzymes, you'll test for troponin. Troponin, you have isomers I and T, and they are specific to cardiac muscle. Elevation of a troponin occurs within hours of the infarct, and it can stay elevated for as long as 2 weeks. So in and of itself, it does tell you if there was any kind of infarct, but as far as timing goes, it does take 4 to 8 hours, depending on where you're looking, and they can stay elevated for as long as 2 weeks. So it's hard to tell if it's something that's occurring now or if it's something that occurred a week or two ago. Your CK is your creatinine kinase, and there are 3 types of isoenzymes. You have your CKMM, which is skeletal, your CKMB, which is heart, and your CKBB. So you will most likely be getting a CKMB because that's going to look at heart muscle isoenzymes. And this will increase within a few hours. It peaks at 24 hours and then falls off. So if you have elevated troponin and elevated CKMB, then the infarct happened most likely within the last 24 hours. They will also get myoglobin. This is not specific to cardiac muscle. It can also be elevated if there's any trauma to skeletal muscle, but it does increase within 1 to 3 hours, so it shows the earliest signs of any kind of muscular damage. and it will peak within 12 hours, so it will fall off pretty quickly as well. So they'll get that test to see maybe that's elevated. The other two are not elevated yet, but you're seeing changes on your ECG that are concerning. That's why they get all three. As far as nursing interventions for a patient with acute coronary syndrome or an MI, you want to get them on oxygen, give them nitroglycerin, chewable aspirin. It needs to be chewed so it can get absorbed in the mucosal lining, and then it gets absorbed in the GI tract more quickly. And then you'll give morphine as well. You give them morphine because it reduces the preload and afterload on the heart, and this decreases the workload of the heart. It also obviously will help with the pain a little bit. Beta blockers can be given if there's any dysrhythmia, and you can give platelet inhibiting agents like alteplase if you think that the clot is completely blocking the artery, and it will help to break that clot up. They have to be a candidate for it, though. They can't have any of the contraindications, which we discussed whenever we talked about the stroke. Patients who have a STEMI, ST elevated MI, are taken directly to the cath lab for a PCI, which is percutaneous coronary intervention, and this is going to open the occluded artery. They have to be a candidate for it. If they're not a candidate for a PCI or the facility doesn't have the capability of getting them in right away, they can get TPA or alteplase, and that will help with the breaking up the clot as well. You'll want to stay with the patient or have someone stay with the patient. They will be on bed rest. They will get vital signs frequently, and they'll be on continuous telemonitoring. They will be on strict I&O because you want to make sure they don't have any heart failure as a result of the MI. You do want to make position changes in the coughing and deep breathing so that they don't have any respiratory complications since they'll be on bed rest. Evaluate your interventions to make sure they are working and report any change in the condition to the physician right away. Okay. There are different types of procedures that can be done. They can have a percutaneous transluminal coronary angioplasty. They can have coronary artery stent placement. They can have coronary artery bypass graft cabbage surgery or other cardiac surgeries. Okay. PCI is an invasive procedure that's done through the skin as a puncture site instead of actually doing a surgical incision. PCTA, the coronary angioplasty, a balloon-tipped catheter is placed in the occluded vessels, and that helps to open them up and restore blood flow. A stent can also be placed to keep the vessel open as well. The patient needs to take anticoagulant or antiplatelet medications in order to prevent coagulation at the stent site or the balloon site. Complications are an MI, so you can actually cause further damage, bleeding, hematoma, arterial occlusion. You can cause a pseudoaneurysm, arteriovenous fistulas, or acute coronary injury. Post-procedure, the patient will be on a thrombin inhibitor to prevent platelet aggregation. They need to remain flat in bed and keep the affected leg straight until the sheaths are removed. And then afterward, to maintain homeostasis, they'll want to lay flat. You need to be careful when you are removing the sheaths because it can cause hypotension, and this can be treated with atropine if it's severe, and they'll give it IV push. After hemostasis is obtained, a pressure dressing is applied, so they'll remove the sheaths and then they'll apply the pressure dressing. Analgesics can be given for pain. If for some reason pressure is reduced, then you can cause bleeding. And so you want to make sure that you look for bleeding at the site so that they don't have any kind of a hemorrhage or a hematoma that forms. Coronary artery bypass graft is a type of surgery. Right here you can actually see the picture. It's done for unresolved angina that's not controlled with medication, or if PCI is not a viable option for the patient. It's also done for left main coronary artery stenosis or multivessel coronary artery disease. It is performed to prevent or treat an MI, can also be done with severe dysrhythmias, as well as in heart failure. They can also do a CABG to treat complications from unsuccessful PCI. So if they went in and it did not help, then they can go back in and they can do a CABG. It is seen less in women, so it means it's seen more in men. The coronary arteries need to be at least 70% occluded, or 50% occlusion in the left main coronary artery. So they generally will go to cardiac cath to see how severe the occlusion and the blockage is. Complications for bypass surgery are hemorrhage, dysrhythmias, and an MI. As far as where they get the vein from, they generally will go in and get the greater and lesser saphenous vein to do the bypass graft. So if you look at the picture, I lost my dot. There it is. Here's the greater vein. And the lesser, the small, is down at the calf. Okay. So they will take that, and if the occlusion is too great and they can't go in and do the ballooning, or they can't go and put the stent in to keep the vein open, they'll actually remove the vein from the heart and replace it with one of those. And you can YouTube it. It's really cool to see if you've not seen it before. There's also cardiopulmonary bypass systems. And with the CPB, a cannula is inserted into the right atrium, the vena cava, or the femoral vein to remove the blood from the body. The cannula is connected to tubing filled with isotonic crystallite solution. Venous blood is filtered, oxygenated, cooled, or warmed by the machine, and then returned to the body. The cannula used to return the oxygenated blood is inserted into the ascending aorta or the femoral artery. Heparin is injected so that you don't get any clotting in the bypass circuit. And during the procedure, the patient is put in a state of hypothermia. And it's just to keep the blood circulating throughout the body, and it bypasses the heart itself. Can be done while they're doing heart surgery. It can be also done with heart transplants, with a CABG, just so that they keep circulation going while they're working on the heart. Okay. If a patient has an invasive cardiac intervention, there are several things that you as a nurse need to make sure that you do. There are going to be orders for frequent blood pressure monitoring, like every 15 minutes. You want to listen to the heart, listen for heart sounds, see if you have any extra heart sounds or any murmurs. Listen to the rate and the rhythm. Check peripheral pulses, look for edema. Look at their ECG because they'll be on continuous monitoring. You'll look at the cardiac biomarkers. They'll be on strict intake and output. You'll assess their skin for temperature as well as color. You're going to look for signs and symptoms of any bleeding, hematoma, or hemorrhage. Signs and symptoms of cardiac tamponade, cardiac failure as well. You need to provide patient education on medication alterations prior to the procedure, so things that they should not take as well as things that they should take, and then also any changes that would occur post-procedure. You'll educate them on cleaning and clipping of the site, especially if they have a lot of hair. Make sure you tell them about all the tubes and lines that they're going to be having post-procedure. Very important, especially for the family members. So when they walk in, it's always a shock, but at least they'll be aware that they should expect. They're going to have several IVs, chest tube. They'll have a catheter. So they just have a lot of stuff going on. They can be intubated, will be intubated initially. So they're going to have that tube. they look a little bit like a mess. Patients after they have cabbages will go to the ICU. It's normal, and they're on ventilators, so it's normal because they're on a vent. But they'll also be on multiple medications and drips and need a very close monitoring to make sure that it was successful and there aren't any complications from the cabbage. Okay. Make sure your patient is comfortable. Make sure they have adequate tissue perfusion at all times. Do not let them become hypothermic. And you'll want to talk to the patient and the family. You can do a lot of education with the family as to what to expect in recovery time and change in lifestyle. And plus all of the things that are going to be out there afterwards. And they generally go to cardiac rehab, so you can educate them on that, kind of what to expect. They're in a long road for recovery, so they can recover, but it is something that's going to take time, and everyone kind of has to pull together to help because the patients are not going to be independent whenever they first go home.